Hi everyone, I am Professor Kevin Fenton, the President of the UK Faculty of Public Health. In today's lecture, I'm going to be reflecting on opportunities for us to maximise the impact of public health in the NHS here in England, with implications for our work across the United Kingdom. This was a lecture that I gave recently to our partners, the public health colleagues working in the NHS, and I thought I'd share it with everyone. So in the time that we have available today, I'm going to do four things. First, really reflect on the changes that have been taking place in the NHS over the past a few years, where we have seen a systematic approach to thinking about the role of public health in the transformed NHS, and most importantly, the importance of prevention and population health. I'll be reflecting on why we need to focus even more now on population health improvement, reflecting on some of the urgent threats and realities. I'd like to also touch base on where we are with prevention, equity, and population health programs in the NHS and some of the opportunities for strengthening them as we see further transformation in the organisation occurring. And finally, I'll end by just reflecting a little bit on our roles as public health practitioners in the NHS and how we might maximise public health advice, input, and leadership in the new NHS. So, the NHS has been under transformation, and as many of you are aware, over the past 5 years, we've seen significant changes in the architecture of the NHS, resulting in new structures, new governance, new ways of working. The recent framework for priorities for the NHS in 23-24 really highlighted the four key areas where the NHS is committed to delivering. First, recovering NHS's core services and productivity. Second, ensuring that there's progress in delivering the key ambitions of the NHS long-term plan. Third, to ensure that we continue to transform the NHS for the future. And fourth, creating a new NHS England in which there's continuing change in how we work. Now, within the NHS priorities, we see a number of core areas where there is a clear link to the work that we're doing in public health. I've highlighted in red, perhaps the area where we're most involved with as public health practitioners. That is helping the NHS to prevent ill health and narrow health inequalities in access, outcomes, and experience. But in almost every other priority for the NHS, whether improving ambulance wait time, making it easier for people to access primary care services, really helping to improve mental health services and maternity services, or thinking about the power of harnessing data, we have a role to play as public health practitioners. And many of us in our public health roles in the NHS are actively involved in informing and guiding those priorities as well. In addition, the NHS operational framework highlights the core principles and foundations under which these priorities are needed to be successful. And this includes a strong financial position, a great workforce, and an organizational improvement culture as well. Now, we are all aware of the new changes which are occurring within the NHS with the creation of new national directorates in the NHS, the strengthening of internal corporate support, the role of regional teams, and how this design really interfaces with integrated care systems and local partners as well. The good news is that public health practitioners are now located in every level of the NHS, and it is the ways in which we continue to work together as a unified family within the NHS that will both strengthen our impact, strengthen our visibility, and strengthen the contributions we make way beyond our designated roles in public health and population health improvement. And that brings me then on why we need to be doing this. Why do we need to look beyond the structures of the NHS and the transformation to look at the urgent need to improve population health? Well, many of us are very much aware of the challenges that the NHS currently is facing with rising demand and reduced supply. And these slides just really show some of the key performance metrics, which many of us working in the NHS are used to seeing when it comes to the pressures on performance, bed occupancy rates, and of course, people being referred to treatment, people being referred and treatment being received. But we also know that there are a range of population health imperatives which are also guiding the pressures on NHS services. Some of these include the stabilization in life expectancy for both males and females, and the significant variations that we're seeing in life expectancy according to deprivation deciles, illustrated on the right-hand side of the chart, where those living in the most deprived parts of the country are experiencing the worst life expectancy, and where stabilization and in some cases declines in life expectancy are occurring. We also know that the NHS is going to be a key player in helping to address the 10-year gap in life expectancy, which we observe between the most and least deprived parts of the country, by focusing on the NHS's role in tackling some of the modifiable risk factors for life expectancy, including work-on heart disease, lung cancer, chronic liver diseases, cirrhosis, and other liver diseases. It is absolutely imperative that not only is the NHS producing high quality clinical care, but also contributing to ways in which we can improve life expectancy moving forward. Similarly, disparities in healthy life expectancy are perhaps even more acute. And we know that we're seeing significant differences in healthy life expectancy across England, and in many parts of the country, healthy life expectancy is not improving. And there's stark disparities in healthy life expectancy between people living in deprived and less deprived parts of the country. And there are good public policy reasons for us to refocus our efforts, both within the NHS and working with our partners, on the main drivers of morbidity at this time, illustrated on the right-hand side of the graph, where we see issues such as lower back pain, mental health disorders, including depressive disorders, headaches, chronic diseases, neck pain, gynecological conditions, respiratory conditions, contributing to morbidity and therefore pressures on health and care services. Now, the NHS recognizes these multiple imperatives of dealing with the acute and urgent, but also keeping a laser focus on its contribution to improving life expectancy and healthy life expectancy. And a key opportunity for this is to reorient and to strengthen the NHS's focus on prevention. Now, this is not anything new. Many of us have seen successive reports being published by the NHS, from the One Less report to the 5-year forward view to the NHS long-term plan, and more recently to the Hewitt review, where there is a consistent and golden thread of an ask to the NHS and to policymakers to increase investment in and the focus on prevention in order to reduce demand, reduce pressures, to build resilience, and to ensure that we're helping to improve population health. Indeed, most recently in the NHS Assembly, there is that, again, reiteration of the key priorities for the NHS in this space. First, prevent poor health, shifting to funding evidence-based prevention measures and collaborating with partners and working to tackle the wider determinants of health, while at the same time focusing on personalization and empowerment and participation in health, by really mobilizing and engaging our communities and ensuring that the patient's experience and voice, especially of marginalized groups, are part of co-creating and co-producing solutions. And then third, looking at how we coordinate care closer to home. So shifting activity back into the community, supporting individuals, and focusing on tackling and improving health. This is further supported by the Major Conditions Strategy, which is the government's main platform, in which they're now encouraging systems to think about rebalancing the health and care system towards that more personalized approach to prevention, the management of risk factors, again focusing on early diagnosis and treatment, looking at how we manage multiple conditions more effectively, integrating on management of physical and mental health, but at the core of this, ensuring that patients have better choice and control as they manage and live with chronic conditions. So this journey towards a greater focus on prevention, a greater focus on personalization, is going to be a key part of sustainability for the NHS in the future. Now, this brings us nicely then to think about, well, what are the most effective interventions in the population health, prevention, and NHS, and where are we with their implementation, and how might we improve their impact? Well, we know that there are a range of population health and health improvement interventions which NHS has a long tradition of delivering and which they're currently tasked of both implementing and bringing to scale. The NHS long-term plan identifies key prevention priorities. For many hospital trusts and systems, making every contact count has been a key part of mobilizing staff and local communities about getting engaged in health and health improvement. In addition, we know that integrated care systems, through their cross-system collaboration and including public health, thinking of care pathways, predictive prevention, and better evaluation provides us an opportunity for better population health management at smaller levels of aggregation of the population moving forward. The NHS also has a role in health protection with the screening, immunization, infection control, and major incident planning. And of course, the NHS has a role in working with communities to tackle inequalities and also address the wider determinants of health and frameworks such as the Core 20 plus 5 and the NHS's role as an anchor institution really ensures that those wider focus on health inequalities is part and parcel of what the NHS does. Now, for each of these areas, we can see not only what the NHS is being asked to do, but what we're learning about some of the challenges that the NHS faces in each. So while there is a clear commitment to delivering the long-term plan priorities, we know that these are specific interventions. We need really good data to ensure that we're evaluating how they're being implemented and their impact. And we have to continue to fund these long-term plan prevention priorities to ensure they have the coverage, scale, and impact that are intended. As we move into more personalized care and as we work towards empowering people to become involved in shared decision making, social prescribing, self management, and personalized health budgets, it's really important to think about our strategies for engaging communities, building health literacy, addressing issues related to public awareness, and ensuring that we have the infrastructures to be able to do this type of engagement with members of the public and our patients most effectively. And third, as we think about the health inequalities function, as we deliver programs on the core 20 plus 5 for adults and children and young people, it is important that we continue to look at data, standardization of practice, community-centered approaches, and thinking about how we continue to make the argument within the health and care system. So these are things we're all learning as we're implementing and as we're delivering prevention and equity and population health in the NHS. I think there are common issues which are going to be shared by all programs. How do you shift the thinking of the health system from the acute and urgent into prevention and early intervention? How do we ensure that we continue to have the resources which are necessary to be able to deliver these interventions at scale? And how do we ensure that we are focusing both on the immediate, but also in the medium and long term, the strategic as well? And finally, for all three areas, how do we ensure we have the workforce that is able to deliver on these? I think that public health practitioners working in the NHS can be part of the solution for all of these key domains of practice in the NHS by ensuring that we have a powerful strategic narrative that explains why we need to continue to focus on prevention and population health. It involves ensuring that we continue to do our work in being able to characterize and define population need and to help with developing robust business cases to invest in early intervention and prevention, to be part of the conversations around budget allocation and allocated efficiency, and shifting to the left in terms of greater investment into community and preventive services. And we certainly have a role to play in helping to ensure that we're continuing to harness this strategic approach to thinking about health and supporting the workforce in the journey around prevention and early intervention. Now, in the final part of the presentation, I wanted to just really hone in now on where do we spend our scarce resources, time and effort to achieve the greatest impact in the NHS, because there's so much we can do, but we have limited resources. What are we learning about prioritization, and what are we learning about where to focus? I think there are a few things which we can really begin to drive forward on, which may be the drumbeat that we need to acquire as public health practitioners and those working population health in the NHS. The first is being clear in our narrative that the NHS is uniquely placed to lead on secondary prevention but it does that in working together with its partners in the wider system. And that secondary prevention role is really, really important because the NHS is uniquely placed to lead action, for example, on CVD prevention, to really begin to build relationships with local government on modifiable risk factors, to really begin to strengthen its outreach into local communities, to really do the things that it can uniquely do, but also to contribute to social and economic development through the anchor programs as well. So placing the NHS and being clear in what it's delivering in secondary prevention, but linking it through partnerships with our partners in the community is something that I think we can and should be advocating for. Second, as public health practitioners, we're continuing to support that strategic alignment between prevention and health equity, recognizing that in our efforts to improve population health, it requires us at the center understanding that we are addressing inequalities in outcomes, experience, and access. That has an impact on how we manage the health of the populations, and then that has an impact on what we do in terms of focusing on secondary prevention. The why, how, what of linking health inequalities to population health management and secondary prevention has to be a clear narrative for practice in the NHS, and a confident one as well. The third thing that I think we should be doing as public health practitioners is to ensure we're using population health management techniques to help to stratify population subgroups and to ensure that we're bringing to bear a range of approaches to both focus resources, focus interventions, and focus engagement for greatest impact. And population health management techniques combined with new data capabilities, including the federated data platforms, should enable us to do things differently, to look at complex problems through a new lens that enable us to both look at resourcing, both financial and human, the ways in which we work with community assets, how we target our interventions, and how we evaluate the impact of our interventions. Fourth, in resource-constrained environments, we must focus on the things that we know work and which are likely to have the greatest impact. And yes, we know that these are really repeatedly outlined by guidance that we receive from both NHS England, from OHID, and NICE, who have collaborated to really produce a resource that really focuses on some of the most high impact, high value secondary prevention interventions that should be in place, whether it's focusing on respiratory conditions, on prevention of cardiovascular disease, improving management of diabetes, or tackling modifiable risk factors. It is our responsibility as public health practitioners to shine a light on evidence-based programs, to shine a light on how we invest for impact, and to ensure that we're resolute in calling for ongoing evaluation, building upon the data as we move forward. Finally, as we think about maximizing opportunities to integrate and leverage and advocate for prevention, I think as public health practitioners, not only should we be in the space of recognizing the financial challenges to really continue to push on NHS lifestyle factors, to really think about optimal approaches and new ways to engage patients, but we may want to think about in the future to be thinking about opportunities, for example, of engaging ICSs in helping them to think about their prevention and community spend, to think about how we continue to focus on the interventions with the greatest evidence base, how we work towards scaling a few things to achieve impact, how we begin to think about integration across pathways, for example, between primary and secondary pathways to address multimorbidity, to think about some of the secondary care focus on prevention, and to leverage some of the new technologies, new vaccination approaches to align them with our preventive services. So the future, I think, is bright, but it requires us to keep abreast of developments, to be in the room with our clinical partners and our technology partners to ensure that we're continuing to advocate for the early intervention and prevention aspects of our work as well. So colleagues, it brings me to the end of the lecture today. I just want to share with you a few thoughts about how we maximize our impact, public health impact in the NHS. What do you think about some of the thinking here in the lecture today? Were there things that were missing? Were there areas that could be strengthened? Are there opportunities that we've missed? What do you think we need to do, and how do we strengthen the visibility, the impact, the advocacy of our voice as public health practitioners in the NHS? Thank you so much for watching. Look forward to seeing you in another lecture soon.